Hello and warm greetings, everyone. Thank you for joining with us for yet another power packed hour of learning and unlearning. Ladies and gentlemen, we are being joined by one of the finest and globally known implantologists, Dr. Aman Pullar. Sir, I welcome you on Dentist Channel Online on the behalf of the entire team, and certainly it gives me immense joy to welcome a fellow Punjabi on board.
Yeah, thank you. Thank you, Doctor. I appreciate the warm greeting, and I look forward to sharing some tips and tricks with the audience today in this webinar.
Certainly, sir. We are looking forward to it as well. Ladies and gentlemen, Dr. Aman is the co founder of the 3D Implant Institute and a key opinion leader for several other organizations. He is a diplomat of the American Board of Oral Implantology, a fellow with the American Academy of Implant Dentistry, and a fellow with the International Congress of Oral Implantology. He's among the 2% of dentists who have received their mastership with the Academy of General Dentistry. He has achieved his mastership in implantology from the California Implant Institute and University of Nevada, Las Vegas. He practices in San Jose, California, with a very strong focus on IV procedures, surgery, and implant dentistry. So, we are certainly looking forward to today's webinar, and I may let our attendees know that they can put in any queries that they might have in the Q&A box given below. They shall all be addressed after the presentation.
Great. Thank you.
So we're
Well,
good to
thank
go.
you. So let me share. Let me grab my screen here and see if I can get access to my screen with you. Okay. Oops, here we go. Okay, great. Are we moving forward with the presentation there now?
Yes, sir. It's perfect.
Okay, perfect. Okay, excellent. Well, thank you. I welcome you, all the participants from across the world that have jumped on this webinar today. I know that there was a bit of a confusion with the timing, and I'm glad I actually waited. I guess there was a very big cricket match in India between Pakistan and India. So as much as exciting as this presentation can be, but I know that I can't compete with the likes of cricket in Southeast Asia. So thank you for joining. I know it's late in India, and I know we've got attendees from Europe and across North America. So thank you for spending some time with me. It's a beautiful Sunday morning here in San Jose, California, and I hope you get some good information from this presentation. This presentation is a precursor for what we have upcoming in November in Kochi, India. We've got 3 days of excellent speakers from across the world that are going to be attending, that are going to be sharing some of the challenges that we can face in implantology. As most of this attendees that are on this call today can appreciate the power that implantology can have in our practices and the benefits that it has. These panel of speakers will discuss some of the things that can sometimes be very frustrating in our practices, the challenges, the not so predictable procedures that sometimes happen, and sometimes even the predictable procedures that have some hiccups and some hurdles that we may face in our clinical practice. So this group of distinguished speakers will share some of their challenges. I've been listening to some of the webinars and the clips and the introductions from everything from zygomatic complications to sinus lifts, to ridge augmentations, to implant failure, to sterile technique, guided cases, freehand cases, full arch to single unit immediate implant placement. The array of topics that will be covered at this meeting will be great. So if you are able to join us, it will be a beautiful location and venue, and part of the world I'm looking forward to see. I've been to other parts of India, but I've never been to Kochi, and I really am excited to be joining these speakers and looking forward to that meeting. So this is some information. It is a well-recognized course across the world with all the major accreditations. So join us, scan that code, get some more information on our website to learn more about the presentations there. So I will be leading a panel discussion and also doing a workshop. My panel discussion will again talk about failures in full arch implant dentistry. So that will be a live event, a podium speaker event, and then we'll also have some workshop presentation with my partner and good friend and colleague, Dr. Hardik Patel, where we'll be talking about managing complications with guided implant placement. And so, which is guided surgeries can be very favorable, but it also has some challenges that practitioners can face. So this is what our topics will be. Well, let's get into it today. I have an hour. I will do my best to cover as much material as possible. It's an incredibly diverse topic and a very topic that usually we spend 3 or 4 days with our participants that join us in our courses and our events. So I will try to give my best version of it in about 60 minutes of people's time. And so I will go fast, and I will try to answer any questions that come up at the end. But we'll get going. This is just a quick sort of a beautiful picture I love to see. This is an example of what we do in our office on a regular basis. This is actually a different printer than we're used currently now, but we can see the power of printing and 3D printing in our offices with a digital workflow. We can print 8 arches in less than 40 minutes in our office with this type of accuracy and predictability and fit direct to the MUA platforms or full arch implant dentistry. So this is the quick, powerful slide, and we'll talk about how this is finished and prepared for delivery in a patient's arch. A little bit of background. I mean, Didi did a great job to share some of the things, my background, and so we'll keep moving forward. It's always important to know that any type of implant dentistry or any procedure we do in dentistry, whether it be surgical or restorative, it has to be driven with a prosthetic background. And so that's really important. I think over the last decade, this has become the guiding principle, or should continue to be the guiding principle when we look at implant surgery. We are not just placing a screw in someone's jaw. We are not just placing it where the bone is. We are placing it with the understanding of where the tooth needs to go, where the restoration needs to go, where the function for this person is going to be. So it's aesthetically favorable and functionally acceptable for our patients that we're serving with these complex procedures. And so there's a lot of understanding to this, to these types of procedures, and it's an interdisciplinary approach. And so advancing our skills is always important. It's a never-ending journey, I feel, that continues to keep me traveling all parts of the world to learn. Just a couple of weeks ago, we were in Brazil learning advanced zygomatic training procedures. So it's something that we continue to do. Here's a slide of a patient that we just recently treated, and we can see how this, if we look at this and we just start planning without a plan or a digital plan in mind, what the outcome's going to be, we can really set up ourselves for disaster. So it's a young female. We can see that she has a high smile line, has a lot of gum exposure, and there's different ways that we can treat this. I will share a couple different ways, and I'll show you a case where I treated this case, a similar case, very differently for a patient, and how we treated this case. And this is an example of these 2 slides show the patient prior to surgery and within 24 hours of surgery. So we can see these types of printed restorations can make a huge impact for our patients immediately in their life. And the design and the process of this type of digital planning is very important. Here is a little bit of a zoom up of her facial characteristics and her oral, direct facial frontal photo. This is day of surgery, just before starting, and then right after surgery, when we delivered the temporary prosthesis. This is a printed prosthesis that is accurate within 5 microns to fit on the MUA. This is all done freehand with no guides to have accurate depth and position of placement to allow for favorable design and function. And this is leaves a very nice intaglio surface. That swelling of the gums that we see around the intaglio surfaces resolves, and within 3 or 4 days, the patient's tissues have responded very favorably for this type of design. Okay, we can see no reduction of bone is done here, and we will talk about how these types of cases can get novice practitioners in trouble because of the transitional line and understanding the aesthetics. And very important to start with the end in mind first, and we'll go over that a little bit further. This is that patient with their final delivery. Okay, this is the final delivery of the zirconia, monolithic zirconia, and we can see a panoramic on the view on the bottom of her case. And she had a midline discrepancy initially to start. And so that's what the patient, we used the midline of her facial midline rather than her dental midline. There was a shift on the lower. So she's very pleased with the final results. Here's another example of a case that comes in, and this is a young gentleman that we just treated in our office just several weeks ago. So I will, in today's presentation, go over how we take records and how we move forward from a situation of this type so that we can have a nice result. We can see he has lost complete function and is a dental cripple, and he's a very young man at this age here to be facing these scenarios. Practices in North America are facing these challenges much more frequently due to the fentanyl crisis and the opioid crisis and the methamphetamine crisis that we're facing in North America with our patient pool. So our practices are changing very quickly from providing these full arch services to elderly patients or patients that have had failing dental restorations to younger and younger patients that are in these hopeless situations that are requiring intervention to live a normal life, to smile, to get a job, to have a partner, to have their children want to greet them and see them. So it's a very, very taxing disability that they're living with. This is an example for that gentleman. We are still in temporary stage. This is the same day delivery of our prosthesis. And we can see the design again is a very minimalistic design. The materials are improving rapidly in the printed resin world. These are all printed after surgery. There are no guides. There are no dentures that we have on our table that we're retro trying to fit. And the accuracy is, as I mentioned, very precise to allow a passive fit on our implants and our multi-unit abutments. This is a printed restoration, again, with a very favorable intaglio surface. I'm sorry about the second picture. I wish wasn't on a white background so that you can see the design of the undersurface that allows for cleansability. I often see pictures on social media and doctors sharing their cases, and sometimes or labs, and the understanding of the intaglio surface is sometimes completely lost. And we need to make sure we keep a cleansable design for our patients. Otherwise, I have some colleagues that call it this is like just a diaper in the mouth because of flanges or unfavorable characteristics or understanding of design. And I'll show you a case similarly of that type. This is the delivery of the immediate temporaries for this type of patient. We can see a nice AP spread. On the upper arch, I do have an implant in the upper anterior right side. If I don't get favorable torque on my implants, less than 15 or even less than 20 torque, I will come back and pick up that implant at second stage. So it does look like a big span from the premolar to the lateral. But there is another implant there I assure you, and I think I may have a P8. Yeah, there we go. Here's a Panorex that shows that implant that's there. So we will pick that up at a second stage. I do have some colleagues that even at 15 or 20 newtons per centimeter of torque will load that as long as there's good stability on the other implants. So it's a preference. I feel like I have a nice stability across the other 4 implants to allow to leave that buried. So, and with the digital workflow that we use, we're quickly able to add that implant into the final or the transitional prosthesis as we move forward through the process for this patient's rehabilitation. This is the patient 24 hours after surgery. Okay, we can see very favorable healing of the gums. We've got resorbable sutures and a very nice transition for this patient. This is the quick video of the occlusion. You know, sometimes we get stuck in the occlusion, and this slide shows, you know, the type of changes that we can make for our patients' lives with these types of services. This is a patient's mom. You know, her mother is so excited to see him. He hasn't seen his results yet, you know, with the mirror. And this type of service brings immense joy to my team, to everyone in the office, from the team that takes the first call to the assistants that take records, because they know what this patient is going to have and how their life is going to just change drastically on that first day. So it's a very emotional experience for this patient. He's looking forward to opening up a small business. His children have sort of disowned him, and he's not able to interact in a public environment, in a social environment. and those things he knows are going to change. And we've seen that result already within we've only treated, this is a recent case in the last couple of months, and we've already seen a huge change in his demeanor. So very exciting for us and our team to provide these types of results for our patient. He goes looking from like this picture on the left side of the screen to the right side of the screen within 24 hours, and this is fixed. It allows them to have function. There are some dietary restrictions that we go over with the patients, but it really allows our patients to have these types of results. So, as we continue to say, well, how can we achieve these results? This is sort of a checklist that I always make sure that we have for all of our cases, and the approach that all of our doctors that go through our institute, that we stress and we really emphasize as needed. Okay, so these 9 things have to happen. Okay, for every case, we have to have this type of criteria met for our surgeries. Okay, and I will go, as you see some of the cases and you see some of the process, you will see how these checklist of 9 criteria are met as we just go through the working of the process of the cases that I sort of go over with you. Okay, here's an example of a case that I took over in a practice that I purchased, and this should have had the lower removable partial denture removed when this plan was taken. So that is a negative here. But the arch we want to focus is on the upper. Okay, it's sometimes hard, and if we were on a live lecture, I would talk to the participants and ask them what they see on the upper arch. But what I like to stress here is that we see that the patient has a fixed titanium or chrome cobalt framework supporting an acrylic fixed prosthesis with nice distribution of implants, and it's fixed. This is not a removable appliance. When I took over this practice, this patient had this delivered about 6 months already, and I had purchased a practice. Got a complicated history where I used to practice in Canada before, and moved to California in 2017. So I had I've done startup practices in Canada and then bought existing practices in the US. So I've had that's another discussion. But in the interesting aspects of that. So we had to find a solution. This is what the prosthesis for this patient looked like when we removed it. And the patient was aware and was very embarrassed and was as soon as even in the dental office, if this was removed every visit and the hygiene was completed, and then this prosthesis was put back in, after the first meal, this is what the prosthesis is going to look like. So she has to live her life with this type of prosthesis and really struggle and know that this is going to lead to a peri-implantitis failure, full arch possible failure. And so we want to avoid scenarios like this. Okay, we want to have proper planning. We want to have understanding of the function of the intagular surface, of the design, of the reduction. I'll go back to my list of 9 things, but I think it's number 2, is understanding proper reduction for the types of cases we're trying to do. So it's very important to have that understanding when we are considering solutions for our patients. Okay, we have to think of the end in mind and what kind of prosthesis we're going to have, whether it be an FP1, 2, or 3 type of prosthesis, and understanding what type of reduction is required for the prosthesis that we are planning. Okay, so this is what we can see. We can see from the sagittal view. We can see here the prosthesis and the phalanges that are there. Okay, we can see the bacteria and the buildup of the plaque and just microorganisms that this patient is living with. So we had to find a solution for her. Again, if this was a live interaction, there's two possible ways to resolve this challenge, and we had to find a solution. So the patient had limited funds, and with a solution that we sought was to actually convert this to a removable scenario. Okay, which is sort of unfortunate in this case because patients pay a premium often for fixed solutions and know it's what they prefer, and to have to go back into a removable appliance is a bit of a step backwards. But if we look at the how we're going to maintain this and function for this patient, that was the best alternative at this stage. We hope to revisit this case with this patient and move to an FP1 design where we can maintain a fixed solution for her and remove the flanges and just have just the teeth, have no gingival contours to the appliance. And I believe we can probably get to a fixed solution again with her. Again, with the power of digital dentistry and the digital workflows that we review, this is all can be accomplished without having a verification jig, without having any try-ins of metal or any framework that we have to verify the fit of with the workflows that we are incorporating in our practice. So here we can see how quickly the tissue is resolved within 2 weeks. This is how she came in on the left with a fixed prosthesis, and we were starting to see some soft tissue and some bone loss around these implants, and we can see how the soft tissue resolved and the condition resolved around her tissue. Even in this anterior implant is very key to see how we've lost soft tissue and how quickly we gain soft tissue back, just with the restoring balance for the body. So our human body and our biology is very powerful, and we are very lucky in implantology and in dentistry that even some of our mistakes, our body can find a solution to resolve often. So this is, we converted that to a denture with locators, and we did a pickup chairside locator pickup, and we the surgeon that had placed these implants was so thankful that we moved this type of restoration, just because he knew where that other prosthesis was headed, and that was going to lead to a failure of the implants and the work that he had completed. So it was a good resolution of a challenging scenario. Here's an example of someone that's edentulous and how we capture their records. It does still require us to understand the principles of removable and prosthetics. So many doctors that come through our programs, they're like, I want to do implants because I hate dentures. I hate removable. And we have to remember those principles of prosthetics that our leaders and our teachers have instilled in us still do matter in implantology and are still the driving factors for our decisions when we use implants and the placement of implants and the prosthetics. We have to start with the end in mind, whether we go to wax rims, whether we get the phonetics and the aesthetics down, and we get the VDO established, know the positions of our central incisors and the maxilla, and then work from there. So those principles that we have for removable still apply to our fixed cases. So you still have to piggyback off that information and knowledge that we have. Here's a final fixed case for that edentulous patient that we just showed you, and how we have a nice distribution of implants and the appropriate use of tilted implants in the mandibular arch to account for the posterior bone loss that's there, so that we can have good AP spread and using principles of tilted and axial implants as a combination in this case. This is her final function. Okay, she looks incredible. Here is an FP3 type of case. Okay, and with a final zirconia restoration, and she's very pleased with the results, and she looks much younger and much happier, and is one of my favorite patients to see when she comes in. All right, so when we're going to get into full arch prosthetic planning, we need to have proper records, and we have a diagnosis. Not every doctor should be taking care of every patient. This is important. You have to, if you're going to be taking on this responsibility, you have to make sure you have the clinical skills and the ability to work through some of the challenges that you may face in these types of cases. These cases can often go sideways, and we've taken over many cases for other doctors and patients that have come in that just report of 30, 40, 50 visits over 2 or 3 years that just still not getting the resolution. And it can be a real thorn in your side. So please spend the time and education to learn these procedures in all the possible scenarios that can come out. I'm still sometimes learning of new things that come out in my cases, that how I need to sort of work through. So having a strong support network of mentors and educators is very important when you're considering these types of cases in your practice, if you are not already doing these cases. Okay, so this is a very useful tool that I find in my practice. It allows me to establish vertical dimension, especially in that gentleman, as I showed in my first case, my second, with that younger gentleman, and even that edentulous female that I just shown, that I think this is showing that patient on that slide here on the upper right, that shows that patient how this works. So, doctors have used the back of a tongue depressor and some dots with a Sharpie. There's different ways to do this. This isn't the only way, but this tool I find is very functional, very beneficial for when we are trying to find vertical dimension, and gives us a good starting point. Okay, this showed this quick little video in a minute shows how this tool works. Okay, this gauge works.
Measure the distance between the center of the eye and the commissure of the lips using the two straight extended markers. Tightening the bolt will lock that measurement into place. If the curved chin marker fits snugly under the chin, you have accurately captured the patient's VDO. If the curved chin marker is not in contact with the chin, then the patient is overclosed. Use your leaf gauge to open up the bite. Backfill the space with blue mousse to stabilize and capture the true VDO. If the rounded edge is short of the nose, the patient is too open. Write down the measurement which you find on the side of the gauge. Unlock the bolt and raise the rounded edge so it will fit under the nose. The difference between the two numbers is the amount required to be reduced.
It's a small tool. There's you can get these on Amazon. I think there's some other alternatives to this type of tool, but it is really a quick something that my team can pick up and help with records without my involvement. I'm not getting paid from any of these things that I'm discussing on here or a sponsor. So this is just some things that I use in my practice and that really allow us to do our job as favorable as possible. Okay, oops, here's an example of that backfill of that mousse type of idea, what we mean for that gentleman that I just started with a case of, and how we are establishing the vertical here for this patient. Vertical from whether you're Pankey or LVI or Dawson, so many different COIs. There's so many different ways that doctors are calculating vertical dimension of occlusion. Okay, it is a range. It is a range for patients that they can function comfortably in. As more and more I learn, and I speak to the greats and prosthetics from Jack Piramati to I.R. Shankar, it is a range of function for our patients that is comfortable, that they can tolerate, and allows them to be at rest, to function well, to have good speech patterns. So this is how that blue mousse is captured, and then we take intraoral scans with that bite. Okay, so this is used with any intraoral scanner in our records appointments. These records appointments capture as you can see, the full palate and also the retromolar pad areas and the vestibular areas for our patients. These areas are very important as we capture, because these areas are going to be needed as reference markers for our full arch digital design as the case moves forward through the process. All right. Very basic retraction and tools are very important to taking good photos and good records for these cases, for having good communication with your lab, for review before surgery. This is one interesting tool here is called a facial meter. It's made by Avoclar Vivadent. It's a annula nose measurement device that allows us to help the lab help design how wide the teeth should be. So if you're able to get access to that tool, your labs will really like you and really think, wow, you're a dentist practicing at a next level. It really helps them to understand what that distance is from canine to canine and to what kind of prosthetic teeth design to consider. So having good pictures that we should be taking, okay, for these cases, having facial, having side view pictures, having a big smile picture, having a repose picture. Patients often have a tough time with repose. It's a very unnatural type of indication for them to say when we try to take pictures, patients don't know what to do. They're often overclosed or open. It is a very difficult mindset to have for that repose picture. And for that repose picture, the best way to sort of get them is to have when they say mum, and just the final resting point after they say a word like that, that allows them to be at rest. And you want to capture that. Okay. And then the other picture that is I think the most important picture is the largest smile that a patient has. Okay. And patients often that have had challenges with their teeth or don't have a very favorable dentition will protect that smile, will have a guarded smile, will often not show you their full extent of their smile. And so it is really important to encourage them to have a full extent of their smile so that they are showing how big they smile or at their biggest smile, because that will help guide us in regards to our design parameters, whether we will be considering this as a FP1 type of restoration, or if we will be looking at other options for this case, understanding transitional line and avoiding scenarios like that last patient that I just demonstrated for our fixed designs. So getting our intraoral scan, getting photos, we do a video that we get function for the patient and just ask some basic questions about each patient, just getting them to understand how long they've had this problem, just to seeing how much lip movement they have in speech or in laughter, getting to see how much the lip moves and how much tooth is exposed. Facial scanners are optional. I'll show you a couple slides of facial scanners that I do incorporate now in my practice. We do use facial scanners. It really has improved our midline conditions for our restorations, and also helps improve canting and really making sure that the arch design in exocad is balanced and is at the appropriate levels, and we have a balanced occlusion and an uncanted occlusion. Fiduciary markers I'll talk a little bit about, and taking a intraoral scan or a soft tissue impression or an intraoral scan before surgery with those markers and making sure those markers don't move through the surgical procedure. Those fiduciary markers can be teeth or markers, and I'll show you examples of this. And how our workflow and the most accurate workflow we've been able to find is with photogrammetry data. Okay. These are examples of some fiduciary markers that are placed. This is an example of what it looks like before surgery. These are fixated into the palate just with local anesthetic, and these are removed after surgery. But these fixated markers establish a fixed reference through surgery. These cannot move through surgery, and they don't, because this isn't an area that we'll be normally accessing or use or interfering with during our full arch surgeries. So you can also maintain some teeth that are used through the surgical that are undisturbed through the surgical procedure. You can also use the teeth, and I'll show you examples of this. This is an example of two different arches or two different cases. Okay, but this is an example of what it looks like before, and this is what that scan looks like after surgery. So the key thing is that these two screws need to look like the same when there were teeth in the arch and not have moved, because that's where the lab is able to mesh the pre-surgical condition with the post-surgical condition to know their proper vertical parameters for the case. So you have appropriate occlusion, as you saw in those cases that I presented, even on the temporary basis. Here's an example of where I did a combination of maintaining a couple teeth, or one tooth actually, sorry, and put in fiduciary markers in the posterior to use. So these markers are placed before the surgery starts, and then that tooth is obviously there present before the surgery starts, and very careful not to disturb that tooth during the extractions and the implant placement. And after this data is captured with the soft tissue, then I remove this tooth and I remove those markers, and we move on to the restorative phase of this case. But these markers are key to be maintaining. So you can use a combination of teeth and markers, or only teeth if they're not going to impede your position of your implant placement. Okay, but always have a plan before you start the surgery of what are going to be your landmarks and your markers that you're going to maintain. Here is an example of maintaining that gold crown at the posterior and placing one marker in the posterior on the right side. The teeth in the anterior were removed, so we use these two markers. I usually try to have 3 fixed markers if I can. Soft tissue markers can be used. This tori areas for these patients will not be violated. So those soft tissue markers can be used, but they're not as accurate if you can understand in alginate or in intraoral scanning to be as stable as the fixed hard stop markers that the lab is going to use to mesh this data with. So, okay, so with photogrammetry, it's been a paradigm shift in our practices, because we're able to do these cases now with much fewer appointments, more accurate results, saving the practice time, chair time, and also saving the patient multiple visits and multiple try-in appointments. We'll show you some of these photogrammetry units at the first couple that were out. This is the two main units. This is one of my partners, Dr. Hardik Patel, will also be with us in coaching. This is a study that we did. We were the first study in the world to compare the two first photogrammetry units that were being used in dentistry. This technology has been used in other fields of dentistry, other than dentistry, for decades. And now the applications of dentistry. This is the iMetric unit that I am holding, and Hardik is holding the iCam unit. iCam, I am holding the iCam 4D, and Hardik is holding the PIC capture unit. We own both of these units. We've used both of them in our cases, and we see the differences between the two. Both are good units. Both work very well. There are other units that I'll show you further along that have come into the market now that are also being established as good products to be able to use. So, and when we do full arch implant dentistry, conventional scanners don't have the accuracy when we go across the full arch, when we don't have teeth references. So that's where the PIC or the iCam or the photogrammetry data is beneficial. This is what the PIC capture setup looks like with a laptop and this sort of Disney device looking robot type of device with two eyes that we see. And these are the capture flags that are used intraorally. Okay. This is how the iCam workflow looks like. It's got 4 cameras rather than 2, and the actual scan cylinders that are used in the mouth are a lot more smaller and less invasive, and allow us to more easily capture implants positions. They are not very bulky, and they capture 2 sides of the corners and allow you to capture even zygomatic and pterygoid implants with ease with the iCam system. Okay, as I mentioned, we have some stackable errors when we look at this strictly impression use. There are some doctors that are using just scanning techniques and specialized scanning techniques. It is a very operator technique sensitive procedure, and I've yet to see a study that shows that the intraoral scanners are as accurate as the photogrammetry data that we're capturing. If we can understand, if we don't have passive capture of the data, we have challenges with the fit and long-term success of our cases. So some of the challenges, as I mentioned, some of the intraoral scanner discrepancies that we can see when we're scanning full arch, we lose some of the accuracy of the scanning, especially when there isn't teeth to have a stitching pattern. Some doctors have used various techniques, from rubber bands to composite to different new scanning cylinders that try to create a Lego type of connection from each implant to the next. But the studies still haven't shown that their accuracy is as favorable as photogrammetry. Here's an example of what as the PIC capture flags look like, and we can see how bulky they are. If you've got 6 implants, or if you've got posterior implants further past in the zygomatic or pterygoid regions, you will have a tough time capturing them all in one scan. And the difference with the iCam versus PIC, I'll show you examples of both videos, is that the PIC has to be from one fixed point, and you have to get a viewing angle that sees all of the scan bodies together. You can move some to get references and maintain some. It is more cumbersome and more complicated and a bit more frustrating for my team. This is an example. When you've got close implants, this will capture with no problem. Even with these implants that are really close in the premolar, in the first molar or the premolar regions, and those further back that are most likely zygomatic implants or pterygoid implants that are most likely pterygoids that far back. Okay, but this will easily capture this location of 8 implants with the iCam, which would be a very challenging procedure with the PIC capture. One of the other favorable things I like about the iCam bodies is that it's a metal to metal connection, rather than whereas the other competitors, whether it be Micromapper or which I will show a little bit, and the PIC capture have a plastic interface that matches the MUA. So I'm a fan. We are fans of the iCam system. We're capturing soft tissue and we're capturing implant position. This quick 1-minute video just shows you how PIC works and how
provides the world's most precise digital implant impression technology. The system is based on the PIC camera that allows to take an impression in less than 1 minute. The PIC abutments are impression transfers calibrated with digital 3D codes. The PIC camera is approached to the oral cavity and the capture begins automatically. Instantly, the PIC abutment's positions are identified and their relative distances and angles are measured. The results are immediately exported to a PIC file that contains the exact positions between the implant platforms. Soft tissue registration must be taken with an alginate impression or an intraoral scanner. At the lab, PIC file and soft tissue data are easily aligned, becoming a high-precision digital model in order to manufacture structures with a guaranteed passive fit on the patient's implants. PIC Dental is compatible with all implant platforms.
So that video shows the same information is pertinent for the iCam system and the iCam 4D, but that cross triangular pattern that it showed you from implant to implant is the accuracy that allows us to capture, which other methods, whether we use alginate or in the analog workflow, where we would take an impression and would require verification jig, try-in of metal, taking a pan, or PAs to make sure everything is seated correctly. And if it's something that's not separating those soldered connections, reestablishing those sections and making sure that we have passive fit. This guarantees passive fit in these cases within it says a minute. Most of my staff is doing it less than 30 seconds, and this is something that I delegate to from my team to do.
PIC Dental provides the world's most precise.
So here's a capture in 11 seconds. Okay, this is using the PIC system. As you'll see, the unit stays stationary because it has one focal view. Okay, and that has some challenges in some cases.
All right,
but we'll see how quickly.
in action, Mariah.
This is my team members. Okay,
Wow,
that's it.
Okay. 11 seconds. Okay, now you gotta do one more time.
So it allows it to be done really quickly. That just shows an example. So I see one of the questions that come up in our chat I took a quick look at was, what's the difference between a scan marker and a scan body? They're used interchangeably, the words. So they're meaning the same thing. These are the scan markers or the scan bodies that are used in the iCam workflow. Here's a good example that shows a lot of things here. This is a scan that has been taken, that is ready to take with the iCam system. We see our posterior fiduciary fixed markers, the gold screws that I placed here. There's multiple screw options that you can use. You need something with good geometry. Doesn't have to be this exact brand of screw. Anything that's got a good geometry that the lab will be able to see and design from. And here they're able to use the pattern of the thread and even the perimeter of the gold screw. And then the teeth as well. Those teeth do not get disturbed through surgery. After the iCam scan is taken, we put in reference cylinders. Those are different from the scan bodies. We take a reference cylinder, and I'll show you examples of that in a moment. And the tissues are sutured together again. And then this is where the capture of the teeth and the gold screws is very important. And the scan cylinders that are placed at these 6 locations on where the implant sites are. Okay. So I'll show you examples of that, but that's to capture the soft tissue position. So, and the occlusion for the lab. Okay. The iCam or the PIC capture allows us to capture implant position, and the soft tissue scan with the cylinders allows us to capture occlusion and soft tissue characteristics so they can design a favorable intaglio surface. Here's an example of the iCam system in action. Okay. This has a calibration plate that is done, because we see variations in temperature. Taking this scan in Texas in 110 degrees, and then taking this in the winter in Minnesota where it's minus 20 degrees Fahrenheit. it will have different results in the metal expansions and how the properties of the scan bodies are. And obviously, you're not going to be in those extreme temperatures in our office, but even the small degrees of temperature change has an impact on how the metals react and position. So this is a scan. This is the calibration. And here, this is an upper arch scan. We can see, I think it has six implants or 5 implants. And you may, I think I zoom back out and you'll see that now the device is actually is moving. It's not a still capture, the 4 cameras. And we can see how those locations, we see five implants have been captured in green, and then we're able to move the next stage. Okay. This allows capture. We can see the tissues are open. If you saw closely, if you saw quickly, there's also the palatal screws are maintained there for that reference that I was mentioning. I apologize. Can we? Okay. Family dog is running that loose in our home. So there we go. Okay. So this shows, this is an important slide. Okay. This shows what I mean with the scan markers, the scan bodies, and then the reference cylinders here on the right side of the screen. This is the same case in various stages that we are through with this surgery. We can see here on the left is where the tissues are open, and we can see on the right where the tissues have been closed. Now we're capturing the soft tissue position and also the 3 marker location of the occlusion for the lab to help with occlusion and also with the soft tissue capture. So after that scan is taken on the right side, and that information is sent digitally to the lab or to my design team, within a few minutes, they're able to say, yes, everything matches correctly. You can remove the teeth and you can remove the gold markers. So at that stage, we remove the markers. And if we're having the patient stay in the office and deliver on the same day, within about an hour and a half to 2 hours, we're able to have everything done with the design with accurate digital files. We're shaving that time to about an hour and a half from sending the data and fabricating the prosthesis from scratch to delivery. And the beauty of this also is that because it's a digital capture, if anything happens through the healing phase, we're able to even print 2 prostheses for all of these cases, so we can easily switch these prostheses out if there's any issues with any fracture or any functional issues there. This is not the only system that people are using with digital technology. Instarisa is another alternative. They use an intraoral scanning technique. There's a doctor in New Jersey that has pioneered a product with different scan bodies that he's able to use. There's a Nexus system that is being used. I do use the system on the right for facial scanning, and you can see along the bottom in exoCAD how that facial scanner helps. I apologize for dry throat here. And then so that data I do capture with the bite, with the facial scanner that Instarisa has. There's other facial scanners that are out there as well, from 3D Shining, RayScan, are all good scanners. Face Hunter. These are scanners that are available to capture how the teeth position and fit in the whole head. These are alternatives now to pick capture and iMetric Micromapper with the release with our good friend Gus, who's got this product that's launching. I have colleagues that are using this, and they're having good successful results as well. Okay, another alternative is OptiSplint that can be used again with the digital. It's sort of a hybrid system with analog and digital, where these scan bodies are placed, and then this honeycomb pattern is placed in the palate if you're working the maxilla, and everything is connected with this with a resin material to have a rigid fixation, and then you scan that framework with your intraoral scanners. So if you're not doing as much volume, or this is not a regular practice or procedure in your practice, these are more cost-effective options you can consider. I'm not going to go into detail of those in this lecture, though, due to time. This is the printer and the setup that I'm currently using, having good success with. This is from Sprint, right? This is the 55S, and this is the Onyx resin, which I've had good success with, and really is a dense material. They're coming out with more and more shades, which is helpful. And Onyx Tough is an updated material that they're providing. And we're seeing even in FP1, where we've got not the tallest dimensions of our prosthesis, we are having success with these prostheses lasting through the healing stages for our patients. Okay, here's some of the printed prostheses. This is one of the old clearing units that we use. We use now we're using a Procure 2 from Sprint Ray, but this shows some of the printing prostheses as they come through on the plates. And this is some of the work that we're able to produce for our patients directly in our office with minimal investment of money. These printers are very cost effective now and very accurate to print these types of work. I'm very thankful for my design team and my in-office team, from my surgical assistants, Mariah and Samantha and Kathy, who have taken over a lot of these aspects. And so I'm able to delegate all these duties to my team, and they just take this on as a challenge and to try to create beautiful artwork. You can see here the printed prostheses are all in one unit, and they have either a B1 or a bleach stage or an A1 stage, and then they characterize and add color and aesthetic characteristics to these prostheses. We can see here on the right side how during transition and how they use implant analogs to create a more lifelike restoration for our patients. And this is just amazing, because that we're able to have this case that we see on the left, we're able to just keep one on site. And if anything happens, if something breaks or something chips, we're able to swap this out. So we print two, and for minimal expense, for a few dollars, having this insurance is very favorable for our patients' long-term success. All right. Here we have a video and showing where proper digital records are very, very important. So seeing this patient has a high smile line again, and it has a partial dentition, and we're looking at this as the upper arch to do a fully fixed solution, where that design is very important. So we capture these records, we intro scan, we're able to put this in our design software. Any implant software, whether you use Blue Sky Bio, I use DTX, Implant Studio, are all good softwares that allow you to do this design. And you can see here for that same patient, what the red is the current and the blue is a proposed placement of these implants and the prosthetics. So having this information before we start the case is very valuable, because then this allows me to know where my implant position will be, how high, how much clearance I need. We're not going to go into those parameters. That's not today's lecture, but understanding those principles of where the depth of that implant needs to be placed based off of this blue design, not off of the red. Okay, red is current condition. When we're making adjustments to incisal edge, whether we're providing teeth to a patient if they're edentulous or have collapsed VDO, you need to know this blue design before you start the case. And that's very key, because this will drive the position depth of the implant placement. And in some cases, if they've got spaces, if they've got crowding, if they've got misaligned teeth, you need to really have this position to know that where your implants are going to go mesodistally, if you're going to be maintaining central fossa access to these implants, or the MUA access, and cingulum access in the anterior regions. You really need to have a prosthetic plan before you start. Okay. Again, if you see those checklists of things, we're sort of checking them all off as we go through. We'll review them at the end. Okay. So as I mentioned, I don't do my surgeries with a guide, okay, with a piece of plastic that goes in the mouth. But there's a lot of planning that goes into each case. Okay. This is what my typical operatory looks like on a Monday morning. I have a dual arch tomorrow, and this is what my operatory will look like, with plenty of notes and understanding of. So it is not a wild west or maverick or cowboy type of dentistry where we go in. If you say you're doing unguided, I would argue this is a guided case. Okay, this is guided by my brain and my planning and the placement and the depths and the positions, MUA selection, even Versa burrs, where I'm going to be using for osseodensification, where I'm going to use a magnetic mallet to help with the removal of the teeth that are maybe a bit tougher to remove, or ankylosed to maintain the buccal plate. So this is a guided case, okay, but not in the traditional sense where maybe we think we have to put a piece of plastic in and pay for a guide and put it in and limit some of the implant locations because you've got to work with a guide. So, and this is that same patient that we showed you just prior. Okay, this is her next day when we deliver. Okay, full arch, temporary restoration. And we can see, you know, when you account for the aesthetics and the lip position, when patients function and they smile, you're going to have predictable results. Okay, you're not going to be caught in a scenario where we showed earlier where you've got flanges in a case where you weren't anticipating. Sometimes we make a lot of alveolar changes. Here's where, as we continue through, as we get through the last portion of our presentation, I do with this with patients that we're doing a lot of
take care of her smile,
alveolar change for this patient.
Understanding what we're doing today, placing up implants on the upper and lower. Do you have any questions?
No, I really don't. You know, I'm ready to get it going.
Yeah, there we go. Okay, great. Nice big smile there. Good. And we've talked about the position of the teeth. We're going to have them a bit higher so we don't see as much gum and tooth that's present. And then easier for you to close your lips over your teeth. Can we just look from the side? Is looking, look straight forward. Okay, good. So we can see the side profile and the smile. Okay, great. Excellent. Good. So great. Well, we look forward to having taken care of you today and working with Max over at California Dental Arts and getting a real nice result for you tomorrow.
Cool.
So this provides so much information to the lab. It's a review of the consent of what we're going to do for her today. Okay, she's understanding these are very invasive, sometimes complicated procedures we're providing for our patients. It provides consent, it reviews the plan, it allows the lab to sort of see where the lip line is. This is not a lady that is not invested in dentistry. If we can see, she's got crowns on almost every tooth. Okay, but just with the biology and her physical features, she has access in the maxilla. We look at the distance here, even between her nose to her upper lip, how much access in her maxilla we have here. And, you know, and she wants a change. She doesn't want to have this gummy smile anymore. And, you know, she's a lady that was able to afford this type of service for herself. And like I said, this is not someone that hasn't been to the dentist. She's had, I think I have a panoramic of her pre-surgical case. She's gone in, she's had restorative treatments done on almost all of her teeth, you know, and she's struggling and she wants a solution. And we can see how much access we had to remove for her bone in this case when we took this approach. And this is sometimes a difficult slide for doctors to see and to see how much maxilla we removed here. Okay. And so there isn't a one cookie cutter approach to each of these cases. Okay. Each case is customized to the patient's needs, and you have to have an understanding of the fundamental principles behind the surgery and the implant placement and what you're trying to achieve for each patient. All right. And so this is pretty graphic, but it allowed me to get the vertical. I knew exactly how much spice I needed to reduce based off my prosthetic plan. As I showed you in that previous case, I knew where the teeth were going to end. I knew where the blue line of the teeth were going to be going forward before I picked up any handpiece, before I picked up any scalpel, because I had the end in mind first. Again, from that first principle, we started off a prosthetic design. Prosthetic driven restorations are key. And so this is what she looked like after, you know, and she's one of my #1 patients and my biggest fans that she comes in. Whenever I have a tough consultation, and I really try to book it, and when she's got hygiene or she's got maintenance appointment, because she comes in, talks to them, and then the patients are just, she tells them she had done this, she wish she had done this 20 years earlier in her life, you know, and she beams confidence and is just a joy to be around, and is just living her best life with the help that we've been able to provide her, and she's very thankful. Okay, so as we get towards the end of the wrap up our presentation. So in these types of workflows, I have a minimum of 3 prostheses for all our full arch cases. The immediate, okay, where we get good, and as long as we have good arch stability, it's on the same day. Tomorrow we're doing a dual arch, upper and lower. Patients flying in for this procedure, or traveling a great distance, and so we're going to take care of that patient on the same day. We're going to take care of the surgery, upper and lower. We're going to take our records. We're going to have our design team on standby. And within 20 to 30 minutes of the completion of our records, they will have a design back. Within 30 minutes, we'll have our arches printed. Within another hour, my team will have everything printed and finished and ready to provide to our patient. And we can get this done in one day for this patient that's traveling a distance to see us. In 4 months, we will check the MUAs, we'll check the torque on these, make sure osseointegration has occurred. We have to always check that, because sometimes you can have implants that have not integrated, and due to the cross-arch stability and the splinting of the implants together, you may have one implant where it hasn't integrated, and it can be deceiving. And it's not always able to be picked up on a radiograph. So always check your torque, check your MUAs, make sure everything is stable as you move forward to the next stages. And at that time, we take a new design, we adjust the aesthetics, the function. We come into our more ideal occlusion, that we have a different occlusion at the immediate plate, at the immediate surgery. And then any color changes, anything that the patient wants to change, we're able to make that in a prosthesis, in a transitional prosthesis. Okay. And then we're able to update that with the patient. The patient goes home with that to try out again. And then as we go to our final delivery, that'll be a milled final definitive prosthesis. Note that I didn't know final. Okay. There's nothing final in dentistry. Okay. If you've practiced for many years, you will understand there's nothing final, and we should get out of that nomenclature for these our patients. Okay. It's a definitive restoration. Okay. It may need to be revisited in the future. Please set those expectations for our patients. We are our own worst enemies, saying this is for life, this is guaranteed forever. You know, we have to remember we're working with a live human body. We don't know what they're happening. We don't know what's happening in their body, how the biology is changing. So please, dentists, surgeons, prosthodontists, let's get out of, let's stop taking the pressure, putting all this pressure on ourselves to call things final, and this is going to last a lifetime. Please don't set those expectations. My brother is an orthopedic surgeon, and you know, we call these types of procedures like a redo. We do things for free. You know, in orthopedic surgery, when they're doing hips or shoulders or knees, they're, you know, it's a revision, and it gets billed again and it gets redone. And just the mindset in medicine is revision, and whereas we call it a redo, or we want to do things for free for our patients. So let's get out of that mindset, doctors, please. You know, let's think like that. Okay. So that's my public service announcement for my soapbox there. A quick moment. So at that, just to wrap up on that, in that transitional set, you're going to take a soft tissue scan. Again, with those same scan bodies, your lab is able to have a library to be able to mesh this back and make any changes in the prosthesis to have more accurate design of the integral surface. There are some gurus out there that are preaching going to final zirconia on the same day, and that movement is, I'm not a believer in that movement. Okay, I believe we still need to allow the integration to occur before we go to such a rigid, fixed final zirconia prosthesis. And I don't think we're gaining a lot in by rushing this process in one day to the final. And so, but everyone has their opinion. So on this, also at that 4-month transitional period, all of our cases, as we deliver that transitional set where we have a mutually protected occlusion, we are taking a T-scan. This is a digital articulating device that allows us to see where the forces of occlusion are throughout the dentition. It allows us to know how they are in excursions, in side-to-side lateral movements, and protrusion. And it allows us to design an ideal prosthesis that is going to be protected long-term. So all of my cases, we use this device. Okay. It's a lot more favorable than using, I still use shim stock, I still use articulating paper, but this has become the gold standard in my practice to be able to have the precise markings with this sensor paper. It's a great technology. It allows us to see where the contact points are with a lot more accuracy, where the first point of contact is for the patient. We have to remember patients' proprioception is off when we've removed all of their teeth and we have no PDL anymore. It is very difficult for the patient to tell you which is coming together first because they've lost that sense of proprioception when we're doing full arch implant dentistry. We have a upcoming presentation coming up in Houston by my other partner, by Michael Tran, that he's going to be hosting in February in 2024 on how to use this device very favorably and very predictably. I'll have some more information in one of the upcoming slides on how to get more information, but he is an expert in this, using the T-scan, and we all learn from each other, and I am proud of the work that he's doing, and he has used this in other aspects of digital full arch or even digital cosmetics and veneers, how this T-scan can be a very beneficial device. Final results, this is for the patient. We know we need to have some restorative space. As I mentioned, I do a lot of FP1 restorations. We still have to do FP3. We still have to do FP2. We have to understand what we need to have for space and what the results are and what the goals are for that patient and what they're coming in with. If they have periodontal conditions, we are still going to need to have a need for FP3 if they've had periodontal loss and bone loss and they've lost bone. Not everything can be an FP1 result, okay? But understanding lip function and movement and prosthetic and minimal space is very important. This is that. think this is that female case that I was demonstrating. So what is the right treatment? Okay. And so understanding, again, the specifics for each case are going to vary. Here we see on the left where I showed you the aggressive bone removal, and here on the right where we see that patient where we didn't do any bone removal. Okay. Both patients are very pleased. Both patients are very happy with the results, but it's the understanding of the principles of what we're going to do and how do we get there. Okay. There isn't going to be one approach for every case. You need to understand what your limitations are, what your goals are of the treatment, and move forward from there, understanding all these principles. Here's another in FP1 that shows the examples of how using with this type of workflow, we're not using tie bases anymore. We can see this is the same arch, okay? We can see when we use tie bases for these multi-units, how in these challenging FP1 cases where the aesthetics and the bulk of the material is limited, we have a very challenging time in these areas where we have tie bases in these lateral locations. But as we with these digital full arch solution, with these digital solutions, with the accuracy that we're able to achieve, I have full confidence in going to full zirconia all the way to the platform, which would really be uncomfortable for a lot of doctors to consider. So by having this type of workflow, we're able to go to straight zirconia to the MUA location. Okay. Okay. So going directly to fixture with direct to zirconia allows for more aesthetic results. So circling back, 9 keys, as I showed you, we went through all of these here. Some of them we didn't go directly, but you can see as we showed examples, all of these things were covered. Having the plan, the reduction is important. Having all these cases you saw were a minimum of 4. In the cases where we're up to 6 or 7 implants in some cases. Having enough length, not being scared of long implants. Having proper width of platform in the posterior regions where the forces are going to be heavier. Don't be using 3.5 implants in the molar regions in these full arch cases. Having lingual access or palatal access to these cases, so the aesthetics are favorable, and understanding the use of MUAs to have more favorable access of the restoration. Maximum AP spread from the anterior to the posterior, using tilted implants when needed, or going into zygomatic or pterygoid implants when needed. Minimizing cantilevers, having cross-arch stability, making sure you have enough torque before you start loading cases. On maxillas, I tell patients if we're not going to get enough torque, we will give them a removable appliance while the implant's integrating. Don't be afraid to tell patients that. Make sure you tell them before you start so they understand that is an additional step that'll be required due to the conditions they present with, not due to something that you've done. This is their problem. You're here to help them. Having a passive fit of our prosthesis is very important, and that's what the iMetric workflow and our photogrammetry data ensures we get, okay, so that we have long-term success of our cases. Okay. We're able to do these types of cases for our patients. This is what our students do in our courses and our programs. They're able to provide and change lives for patients. As I mentioned, some of these patients are elderly, and unfortunately, we're seeing more and more younger patients that have had challenges in their life that are appearing, and you can really make a positive impact on these patients if you understand the surgical and the prosthetics in one location. Patients love to see you for the both aspects of the procedure. They know that you are there to see them through. They have confidence in you. They see the work that you do. You create. You become the authority in your community. Provide these types of services, and they're just so rewarding to see the change in people's lives, whether it be their family, whether it be their lifestyle, their employment. It just they beam confidence and they radiate just so much more. Such a more zest for life. And these are our doctors. Our doctors are doing, this is a case that was done by our doctors, not by myself. This is the doctors that we help learn these procedures with. So this is a quote that Dr. Iyer placed a couple of weeks ago, and it really has stuck through with me, and learning these complications and learning complications that are going to come up. And, this phrase is just, I feel like it's embedded in my head because it needs to be, because, we can overcome with increasing our knowledge and our understanding and our knowing different scenarios that may come out in our cases, if we continue to get more information and understand these complications are going to happen. And if you're going to have a long career in this type of hard, complicated procedures, you need to be able to balance and understand that these things will happen. But having also a way to resolve these tough scenarios is so key. And that's why we invite all of you to join us in Kochi, because we will cover so many aspects of these types of scenarios. And my lecture will be dedicated to sharing some of the failures and some of the challenges that we face. And we've all been able to I've come able to resolve all these scenarios, but learn from our mistakes so that you don't have to have them. And if you do have them, you know how to handle them, maybe with a less stress and a less challenges that we've had to face. So we look forward to having participants join us and continue to go through. This is how I can be reached. Okay, this is join me on social media. I'm on Facebook. I'm pretty active there. We share a lot of our cases. I'm on the gram, as the kids would say, Instagram. This is our website on the bottom. It shows some of the offerings of stuff that we have upcoming. We've got hands-on courses. We have didactic courses. We're launching a maxi course in Dallas, Texas in 2024. So, which will be very solid didactic and also surgical components and hands-on components. So, we look forward to having you join us in Kochi. And it's a beautiful area, I'm told. Just amazing areas to tour around. My father is joining me there, and we look forward to touring around in an area that he has never been to as well. My wife wishes she could come, but we have 4 children, and it is a busy time of year, just as this year is wrapping up in November. So, but I appreciate the opportunity today to share some of my experiences. And we've never provided such a condensed course with so much information for in a pro bono or a complimentary setting. So I hope practitioners are able to get some good resources and good information that they can apply and maybe learn more about. And we're happy to help them in their journey of understanding these principles further. Stage is yours, Aditi.
Thank you so much, sir. It was indeed a power-packed session with you. Thank you so much for your words of wisdom. And we certainly got to learn and see from some of your really revolutionary work. And it was amazing to see that. Thank you so much, sir, for your worthy insights into digitally driven implant rehabilitation.
Sure.
And ladies and gentlemen, Dr. Aman will also be enhancing the value and validation of the World Implant Expo happening in Kochi from 26th to 28th of November this year. Make sure that you use this opportunity to the fullest and enhance your skills and knowledge. Thank you, sir. We have a couple questions before we conclude today's session. Shall we take those up?
Yeah, definitely. I'll do my best to answer them. As I mentioned, this is a jam-packed, this is 3 days in our courses normally, and I've tried to give all just the key components. And so it is very typical to have questions. I will try to answer them as best as I can. One of the first questions are PINK transfers. Are they similar to scanned bodies? They are sort of in some aspects, but they're not, we can't be using our similar. They go in the multi-units. PIC capture actually has they can go straight to fixture if you wish, but as you can understand, each implant system will have their own internal connection. Hyosen will be different than Nobel. Nobel will be different from Straumann. Straumann will be different from Megagen. So it gets very costly with these flags to have for each implant system, but PIC capture does allow you to go to the fixture level rather than the MUA level. But most of all the cases I presented are going to the MUA level, the standard Nobel MUA connection, which is used throughout the industry on most implant companies. There are a couple like Ritter that don't use that system. They have a different size for their multi-unit, but the majority of implant systems use the pioneered Nobel platform, which is so all the PIC flags, all the iMetric scan bodies are compatible to the Nobel system. Okay. Facial scanner company. Someone's asked, there are multiple facial scanner companies. What I showed you, the blue one that I showed you there was InstaRisa has a facial scanner. They have a 2-part procedure with this impression material, which I'm not as much of a fan, but people are using that with success. their doctor that is the founder of that is Art Morales.
Shall I read the
He
next
does a nice job. Sorry. Oh,
sorry, shall I read the next one out?
Sure. That's one company. Facial Hunter is another one. 3D Shining is a facial scanning company. RayScan has one. A lot of industries, a lot of companies are moving into that facial scanning world. So you have some multiple options to consider. You can consider. The next question. Do you always remove infected posteriors at the time of implant placement with your workflow to achieve FP1 results? Or do you ever remove infected posteriors and graft and then come back 3 months for implant placement and immediate load temporization? Great presentation. Very good question. Each case, again, is very unique. I've got patients that I'll come in and, a lot of patients are seeing advertisements, especially in the US, of same-day dentistry, of full arch. And, we do have to evaluate each case. I've got patients that we still see that we will graft, remove the infection, and do this in a staged approach. In your question, sir, that you're also measuring, I will often do this as a transitional case for full patients. So if I've got some infected teeth, I will remove those infected teeth, and I will use the existing dentition as a transitional and do traditional crown and bridge as the infections are resolving. Sometimes I can place implants at the same time and bury them and leave them, and then come back and then flip, or I have to graft completely with these infected areas and just use the teeth for temporization, and then come back at 3 or 4 months later and then place implants and then flip it and then take out the teeth and then now use your implant locations as your temporary. So it's a lot of creative thinking. It's not always, I didn't show a case, maybe in my next presentation, I'll add a case where it has a tooth-borne temporary stage of transition to deal with a major infection. In some cases, the infection is so rampant, especially in the maxilla, because you've got such poor bone, even initially to start, and you can't get good stability. I will do a full clearance, do grafting, give them a denture, and some to come back in 4 months. It's just on how you communicate to your patients and get them to have the understanding. I mean, they're spending a lot of money for these procedures in the US. I mean, across the world, but in the US, it is a very costly procedure. And we want to have success long-term. We don't want to have to revisit this case. We don't want to have failures. So that's there. So there are different ways you can do that. So every case, again, I stress, understand the principles, and then you can apply it to any case that walks through your door. And then you can be very successful with these procedures. Yeah. What is the name of the white measuring instrument you were using? White measuring instrument.
The probe.
Well, there's a white probe
Yeah.
that I just used with the white plastic probe. That's just a white plastic probe that we had. And then also there's the facial meter. That's from Ivoclar, that has that facial meter that showed the ruler that shows with the nose. But otherwise, I use a probe. I'm assuming that's what they meant. That.
Right.
And thanks, great presentation. Are PIC scanners attached to multi-units or implant level? So that's good. I hope I answered that earlier. It can go either way for the PIC system. But one of the beauties of that system is that it can go to the fixture and it can go to MUA. You can pick. But if you understand, as I mentioned, if you go to fixture level, every platform, if you have an NC and an RC platform, an RP or an NP platform, those platforms are going to be very challenging because those PIC flags are very costly. I didn't really get into the cost of these devices, but they are sometimes cost prohibitive to use in all aspects of the world. And that's why I shared some of the OptiSplint, which is a nice cost-effective solution. So to encourage doctors to understand that they can use these digitally driven procedures in their practice without photogrammetry. I just find photogrammetry is the most predictable and easiest within, as I showed you, within 10 seconds, 15 seconds, we're capturing these results without any impression material, without anything else in their mouth. Just the accuracy is it's too easy. So for a very complicated process. What else have we got? Excellent work. Keep sharing. Thank you. Scanner name. Are immediate prostheses attached to MUA? Yes, immediate prostheses are attached directly to MUA, fixed with different various screws. I use a desk screw or I use a sin screw. Powerball is a great screw. There's a Rosen screw can be used. There's a vector screw that's being used that can be used. That all they go straight to MUA. Scanner name, low cost that we can set up for full mouth cases. Low cost is the OptiSplint is probably the most cost effective solution with the materials that I showed you. go through the presentation again, do that slide. This is all be recorded. You can go back to that slide and look at that and the contact information. But OptiSplint is probably the most cost-effective per case solution. If you're not doing a lot of these, or if you're not doing these on a regular basis, that is an alternative that I shared. How long lasting implants of bone is actually capacity is low? This thing does not want to. How long lasting implants if bone healing capacity is low? Not want to wear anymore. I don't know the context of that question. What type of implant material was used in the last case, doctor? Implant material. I'm assuming prosthetic materials. A lot of the prosthetics I'm using now are mostly monolithic zirconia. Okay, high quality monolithic zirconia pucks that allow us to get nice, favorable results for our patients. They've really improved. But there's alternatives. There's there you can use still a PFM approach with the metal framework. It can still get really, really good results. Chrome cobalt frameworks, titanium bar framework in some of these cases. You have a lot of options to consider that are good. How do you select the MUA when the implant is freehand? Yeah, that's a good question. That selection is based off of the prosthetic plan that we have before, and I didn't show here, but it's more of a surgical based. We didn't really have a full surgical based presentation today, but I use a guide. I use some, or I can use like an open channel guide to see where the teeth are going to be, the incisal edges, and to be able to help with the MUA emergence. That is helpful sometimes. Using the existing teeth can be a helpful guide to see how they're going to close. And sometimes when you do freehand, you do risk not having it in the right spot, and you may have to come back and change that MUA in the later stage. Sometimes in my temporary stages, the emergence of the anterior implants may come out on the incisal edge or slightly buckle. I'm not so worried in the temp stage. We go with it, and then we change again. We can change that MUA in the transitional phase as we get to the 4 months of healing, and then we're able to change the MUA and quickly capture digital records again because it's so quick, and then keep moving on with the process. Same thing when we have buried implants, we put an MUA on at that second stage and capture and add it into the prosthesis. Yeah, good. Well, that looks good. Looks like we've answered all the questions. Some good questions. It looks like there was a really attentive audience. Great to see.
Yeah, it was, sir. With you, we will always have an attentive audience. Thank you so much, sir,
Thank you.
for patiently answering all the questions.
Yeah.
And your 9 simple but very crucial keys to successful full arch rehabilitation are certainly going to go a long way ahead with us. And
Thank you.
once again, thank you for letting us squeeze into your busy schedule. We really look forward to learning from you in Kochi.
Well, we look forward to seeing a lot of the attendees in Kochi, and please join us. Again, like I said, we'll have a wonderful array of practitioners from across the world, and I'm looking forward to learning so much at the meeting as well. And I look forward to meeting you in person, Dr. Aditi, at that time. Thank you.
Same here, sir. Same here. Thank you so much, sir, for your invaluable time and wisdom once again. Have a good day ahead. Thank you so much.
Thank you. Okay. Thank you very much. Okay. Bye-bye.